Dear friends, very good morning. In this lecture, I am going to give you a brief overview or an algorithmic overview of hypovolemic, cardiogenic, and obstructive shock. Now, this is important for the simple reason that whenever a patient presents with shock, it is important to distinguish these three components, but at the types. But it is also true that many a times there are overlapping features of the components. So if we follow a particular algorithmic pattern and if you're particularly careful in the evaluation process, then probably we will end up correcting the important deficits early. And even if a shock can happen because of multiple reasons and there can be overlapping features, the need to correct any particular feature before the other becomes crucial in patients with such mixed pictures, and therefore this is extremely useful. Let us see this case, and as we walk along this case, we will try to pick up the relevant features. A 30-year-old male presents with breathlessness, chest tightness, and altered sensorium for a day. He had history of passing loose stools before 2 days, repeatedly on many frequent accounts. Patient had a mitral valve replacement during childhood following rheumatic heart disease. And on examination, heart rate was normal, the blood pressure was normal, the respiratory rate was fine, the saturation was still within normal limit, 90% of room air. The chest and CVS were normal, but the abdominal was tender. The USG, the point of care ultrasound, was normal, and the abdomen at the bedside. The chest X-ray was normal, and the echo showed a normal LV function with no clot, normal wall motions. The counts were high, or 14,000 TLC count with more than 80% polymorphs. The lactate was just above the normal level. The PCO2 cap was 6 millimeter. So it was also roughly more or less at the threshold. So first question that comes to mind is that, is this patient in shock? So if you go by the microcirculatory characteristics, we know very well that in order to label that patient as a shock, you will have to show organ dysfunction. Now, in this patient, there was no organ dysfunction, but still that the patient was progressing at deteriorating rapidly. So organ dysfunction was likely could have occurred at any point of time. So there are certain pitfalls of diagnosis and management of shock that no sign, symptom, or investigation is entirely sensitive or specific for its shock. So we will have to sum up uh, those features in order of their severity to assess on the manifestations. The clinical presentation is not uniform. We all know that there is a component of warm sepsis and and in hypovolemia there can be cold sepsis. So the warm, the vasodilatory shock, etc., makes certain times the clinical presentations brings a non-uniformity. Patients can have a combination of more than one form of shock, which is a multifactorial shock. Patients can have abnormal baseline values, which can confuse the multifactorial picture, because if it is on the background of a primary disease, certain forms of shock share overlapping features. That is, late septic shock may look quite similar to advanced cardiogenic shock. And despite thorough evaluation, the shock may remain unclear, or in that case, we label it as undifferentiated shock. So the most common causes of shock of unclear etiology, you keep in mind that it is septic shock. Now, there usually the shock passes through three stages. The first stage is the pre-shock or the compensated shock, where in patients you get compensatory mechanisms are running the roost, and therefore they tend to overcome all those challenges. So the decrease in tissue perfusion that is occurring in shock is offset by certain features of compensatory mechanisms or drive by tachycardia, by peripheral vasoconstriction, changes in systemic blood pressure. So everything increases. Next stage, in the shock stage, the most classic signs and symptoms appear, because that is because of early organ dysfunction, because they are resulting from the progression of the pre-shock stage and the compensatory mechanisms have started failing. So they're moving on towards the shock. And in the third stage, it is the end organ dysfunction, which is the final stage where there is irreversible organ dysfunction, multi-organ failure, and even death if therapy does not bring back, restores normalcy. So there is this, at what rate a patient will pass through it of this stage, how long the patient will be in a particular stage can never be guessed. It can be guessed, it can be a guesswork, but it cannot be definitely stated. So it is very important to understand that how the patient is behaving at any particular point of time to assess that what is the likely prognosis. So a very important thing is to evaluate. So how to evaluate? Now, if you look into the hypovolemic shock, you know that the types of shock are the hypovolemic shock, which may be because of hemorrhage, either in the setting of trauma or because of fluid losses from severe vomiting, diarrhea, whatever. So they are produced, their volume deficit. So this is the perfusion fails, and this patient quickly progresses to acute renal failure, etc. Cardiogenic shock results from decreased cardiac output because of an intrinsic heart defect, often from myocardial infarction, valvular rupture, congestive heart failure, and so on. Obstructive shock results from physical obstruction that reduces the cardiac output and may be because of cardiac tamponade, massive pulmonary embolism, tension, pneumothorax, and such conditions. Distributive shock is most commonly due to sepsis. It can also occur in other forms of distributive shock like anaphylactic shock, but it is most commonly due to sepsis and overwhelming infection, and it can occur also following neurogenic shock in spinal cord injury, etc. So if you look into the individual parameters carefully, you will find that all the cardiogenic and the hypovolemic the classification and the septic, if you consider, if you remove from the list the others, so you can see the cardiogenic, hypovolemic, and septic. If you try to distinguish these three in particular, you will find that hypotension is present in all. The systemic vascular resistance is low in septic shock, high in others, because septic shock is a vasodilatory shock. The cardiac output is high, therefore, maybe in the initial stages of septic shock, but subsequently also it falls, but it is low in the other two. Cardiac preload is high in cardiogenic shock and low in the other two. Venous oxygen saturation is high in the septic shock, and the urine output is low in all, and the skin temperature is one. So this is one of the ways by which you can relate some of the clinical findings and some of the findings on the monitor to distinguish between the three when some overlapping features are present. But it is also important to see that the classical appearance of septic shock versus cardiogenic shock is also important, because if in heart failure versus septic shock, in sepsis, clinically the patient generally looks sick, often tachypnic, delirious, and febrile. But in heart failure, this look is usually absent. So the patient may appear normal, may have normal mentation despite a falling cardiac output, and this distinguishes the two. In the blood pressure, there is wide pulse pressure with very low diastolic pressure in sepsis, whereas it is a narrow pulse pressure because both systolic and diastolic are reduced. So this is a feature of heart failure. In the skin, it is initially flushed, warm extremities, and initially the capillary refill time is normal in sepsis, whereas the extremities are cool, poor capillary refill, and there can be mottling appearance in patients with heart failure. In both cases, the urine output will be low. So these are some of the ways to distinguish between septic shock and cardiogenic shock if in the presence of overlapping features. Now, diagnosis of shock should be highly suspected in the presence of more than two of these features. That is, in hemodynamics, if it is altered, hypotension, either tachycardia, bradycardia, tachypnea, to identify patients at risk of clinical deterioration. If there is oliguria, that is urine output of less than 0.5 mils per kg per hour, it is a worrisome. Mental status changes, agitation, confusion, delirium, etc. Skin perfusion status, cold, clammy skin, mottling, urticaria, etc., or elevated lactate, which suggests shock. And there are several scoring systems like Apache 2, SOFA, QSOFA, NEWS2. that can predict and evaluate the outcome of critically ill patients for prediction of mortality. Now, it is very important to evaluate the cause of shock. Do not wait to gather a complete history or perform full physical examination that we do routinely in the bedside in a non-critical ill patient. So hemodynamic stabilization must be prompted before identifying the cause of shock, because time is a very important factor that determines the prognosis. Some specific signs and symptoms can potentially suggest certain causes of shock in appropriate setting, like chest pain, dyspnea. These are features of acute myocardial infarction, acute aortic syndrome, pulmonary embolism, etc. If there is abdominal pain or back pain, that may suggest ruptured aortic aneurysm. Leg size discrepancy, pulmonary embolism, fever, shaking, chills, productive cough, lower urinary tract infections, peritoneal signs, skin rashes, all these are indicative of sepsis or septic shock. Hematemesis, hematochezia, bleeding, all these indicate GI bleeding. So we will have to identify the specific signs and symptoms quickly so that we can digress into the more specific causes rather than exploring all. And labs, imaging, and ECG are definitely important. So in the bedside evaluation, if you look at the monitor, you know the narrow pulse pressure less than 25% systolic, it suggests low cardiac output. Wide pulse pressure with diastolic hypotension suggests high cardiac output. In the echo, you see the right ventricular size and function, because if you suspect pulmonary embolism, check for the DVT. In all those cases, you can get a right ventricular strain. Left ventricular size and function, mitral and aortic valves, IVC. If unable to see the IVC, one can see the internal jugular vein to see the fullness. And pericardial effusion also one has to look out for if there are features of obstructive shock. Similarly, we go into the lung ultrasound, the abdominal ultrasound, and skin perfusion, and we know that what to look for in each of these bedside investigations. So if you see we have to go for the investigations and workup in the lactate, CBC and differentiation, renal and liver functions. Extended electrolytes means not just look for sodium, potassium, and calcium. We also look for magnesium and phosphorus. Coagulation profile, troponin, particularly if patients are suspects with out of AMI. The D-dimer value, a lower than the cutoff for age in patients with a low to intermediate pretest probability of having a pulmonary embolism, it can rule out P. So in suspects with pulmonary embolism, D-dimer value has importance. The BNP of less than 100 pg per ml or an NT-proBNP of less than 300 indicate that the acute heart failure is unlikely. So these we have to do so for exclusion, that is for the, even if the sensitivity is low, the specificity is high. So we have to undertake such investigations. For lab investigations and workup, for sepsis evaluation, infectious workup we have to go for blood cultures, urinalysis, procal. If a decision is made to treat with antibiotics, then check a procalcitonin, type and cross-match blood if hemorrhage is suspected, and look for the cortisol level if adrenal insufficiency is possible, and also to the TSH if thyroid storm is suspected. So an endocrine evaluation also finds place during assessment, depending on the presence of manifestations. ECG is used to identify arrhythmias, ischemia, or changes consistent with certain toxidromes. A lot of time patients presents with features of shock is actually because of poisoning and or use of drugs and everything. So we have to identify the specific toxicities and the features related to that to start thinking about an antidote. So POCUS is very important, the point of care ultrasound, in identifying the etiology of hypoperfusion. If we go for the upper and lower blue points, then if they're present, then check for the B profile and the A profile. If any of the A or B profile are seen, then we diagnose pneumonia. If these upper and lower blue points are abolished, we check for A dash and B dash. If B dash is present, then it's pneumonia. If A dash is present, we look for the lung point. If the lung point is there, we identify pneumothorax. Without lung point, we have to do other modalities. Maybe we need to do a bronchoscopy to see what are the features. So likewise, in case of A profile, we have to see for sequential venous analysis. In presence of thrombosed vein, it is P most commonly. If there are free veins, we have to go for the PLAPS point. If it is positive, then it's pneumonia. If negative, then it can be because of COPD or asthma. So this follows the routine algorithmic processes of POCUS, but this is very important to assess once we are sure about the hypoperfusion. So this is the schematic of bedside lung ultrasound. So it is we all know that. The false protocol also follows Wells classification of the shock. So ruling out, it searches for the pericardial fluid, then for the right heart enlargement, and lastly, the abolished lung sliding. So both this blue protocol and false protocol are very useful. And if you follow the steps of the false protocol, you can rule out obstructive shock, then rule out cardiogenic shock, then rule out hypovolemic shock, and detect distributive shock. So this excludes pulmonary edema that in clinical practice is left cardiogenic shock. So both of these are very useful in the setting of shock to understand and implement proper management. And this one single slide identifies all the features of distributive shock, hypovolemic shock, the LV failure because of non-mechanical causes, LV failure because of mechanical causes, RV failure, tamponade, tension pneumothorax or hemothorax, autopeep in presence of high intrathoracic pressure, and what the findings would be with regard to the cardiac output, IVC size, left ventricular ejection fraction, etc. So if you look into the lung ultrasound, LVEF, then all the RV, the right ventricular enlargement, watch for the additional POCUS findings, then most of the cases you will be able to reach the goal and guide the proper management. For instance, if you see that if it is a liver failure, as you can see, mechanical, which can be because of either left ventricular outflow tract obstruction or severe valvular insufficiency, you can get bilateral B lines. So if there is a bilateral B lines with severe MR or ER, then automatically you will be able to focus on left ventricular outflow tract obstruction. And if you see a systolic anterior motion and MR jet, then you definitely consider LVOT. So consider in those cases the aortic dissection in the presence of aortic root flap, etc. So similarly, if lung sounds, if they are absent on the affected site during lung ultrasound, then there is a high probability of tension pneumothorax or hemothorax. So one can easily look into it. Therefore, this is a algorithmic approach which becomes very useful, important, easily available, and it can if you can just print it on your memory, then it can solve a lot of problems and save time. So initial stabilization is very important because it approach in all patients in a systemic fashion using the airway breathing circulation approach. The methodology is unaltered. If intubation is indicated, we have to correct hypotension with the push dose pressors before proceeding for intubation. Avoid intubation if patients are having suspected of obstructive shock like pulmonary embolism, tension pneumothorax, or cardiac tamponade. We have to correct the primary per se because the patient otherwise can go into arrest. Administer supplemental oxygen targeting a saturation of 90 to 94%. Consider CPAP or BiPAP for patients with cardiogenic pulmonary edema because they respond quickly, more quickly than others. The basic principles of circulatory management is to correct the heart rate first. If dysrhythmias is suspected as the primary cause of hemodynamic stability, dysrhythmia is likely the primary cause of hemodynamic stability. If the heart rate is less, there is AF with rapid ventricular response of more than 150. If there is non-sinus tachycardia greater than 170, so in all those cases, the dysrhythmia is likely the primary cause of hemodynamic instability. So that needs to be corrected. Second is to correct the volume status, if appropriate, before correcting the resistance problem. Third, the resistance problem, that is the pressures by use of vasopressors so that the tissue perfusion improves. And fourthly, we have to consider inotropic support so that the cardiac output improves, if at all it is indicated. So establish more than 2 large bore IV cannulas, a central cannula, or in children or in extreme cases intraosseous access so that high volume of fluid resuscitation can be done and vasopressors can be administered. When and how to administer fluids? Fluids is often given in bolus patients in 500 ml with consideration to the patient response. Always consider balanced crystalloid solution over normal saline because of the risk of the chloremic metabolic acidosis. Limit the total amount to 1 to 2 liters in the absence of history suggesting substantial total volume depletion, because you can always look into the filling status of the heart or into the IVCs before going for further. Hold IV fluids if signs of pulmonary edema appear or they are present at any point of time on examination or bedside ultrasound. Avoid fluid boluses when there is bilateral B line in the USG, which may have LV failure and pulmonary edema, or in patients with dilated IVC without respiratory collapsibility, which have a elevated filling pressures, and because these are the ones on the steep part of the Frank-Starling curve, and they're unlikely to be of any benefit from the fluid administration. When and how to administer the vasopressors? Vasopressor administration, you should start if the MAP is less than 65 after fluid and patients with impending cardiac arrest. They may be administered by the peripheral vein except for vasopressin. So forget the previous dictum that vasopressor should be only administered through the central vein. No, they can be administered. However, the peripheral vein, it is good to use a thick peripheral vein. Norepinephrine infusion is the first line vasopressors for undifferentiated shock along with suspected septic, cardiogenic, and neurogenic shock, and the dose is well known to majority. Epinephrine infusion is an appropriate alternative to norepinephrine for undifferentiated shock, especially in bradycardic periods, but as we know that it increases certain factors, the lactate increases, the arrhythmias can increase it. In anaphylaxis, epinephrine followed by epinephrine infusion, that is intramuscular, followed by epinephrine infusion. And in vasopressin infusion can be added when a single vasopressor alone is insufficient. So, but you know that vasopressin is 0.01 to 0.1 units per minute. And once this dose is reached, there is no point in escalating further. When and how to administer other inotropes and other drugs? Dobutamine, that is 2 to 20 mics per kg per minute with a maximum of 40 mics per kg per minute, can be added if low cardiac output is suspected in patients with signs of ongoing hypoperfusion, despite adequate intravascular volume and appropriate dose of vasopressors. Antibiotic, if sepsis is possible, culture should be performed. Empiric antibiotics should be started after sending cultures. And steroids for suspected adrenal crisis, like patients who are known to have adrenal insufficiency, patients who have been taking chronic steroids who missed doses recently, septic shock with persistent inability after appropriate fluid and vasopressor therapy. In all those patients, you can look for steroids. And as appropriately said, that once the situation improves, we can taper off or de-escalate as per in the similar fashion in which we had started. Now, I'm just going to cite a few examples of the questions that are commonly asked in some of the international exams. Elderly gentleman presents to hospital with a recent history of chest pain and breathlessness. The echo shows ejection fraction of 30% with apical ventricular septal rupture. The patient is in shock, ARF, and ischemic hepatitis. Put on dobutamine and furosemide infusion. PA catheter is inserted as a part of preoperative stabilization because this patient might need cardiac surgery because of ventricular septal rupture. The following parameters are displayed are representative of patients and true physiological status. PA pressure of 60. So these are the typical types of K type of questions. We have to identify the true and false. The PA pressures of 60/2/28. Cardiac output of 6 liters, cardiac index of 3.2 and SVR of 700, CVP of 18, SCVO2 is 40% and MVO2 is 70%. So if you have to choose the true answers and the false ones in this list, in K type of questions, you can do that based upon the findings which you can see and try to relate it with the values which have been put against the parameters as response. So another type of question, the direct parameters, you know that CVP, PA pressures, wedge pressures are true and reflect patient condition. The cardiac output, these are all derived parameters, cardiac index and SVR, they Not correct, because they calculate the right-sided cardiac output and tend to overestimate the systemic cardiac output, cardiac index, and because of the increased right side flows because of left to right shunt. SVO2 often overestimates the oxygen because of left to right shunt. So accordingly, you will have to choose the responses. So these are all exam oriented questions which may benefit to, students who are sitting for such exams. I cite one more example, that this is a 45-year-old female presented with sudden onset pain in the right lower limb, has past history of hospitalization with cough, breathlessness for 3 years, history of hemoptysis, joint pain at young age, heart rate is 170, irregular heartbeat, BP is 80/60, urine output is reduced and dark colored, echo shows giant LA with spontaneous echo contrast showing severe calcific MS. Now, which one of the following statements do you think are true or which are false? So the patient is on acute and chronic cardiogenic shock due to decreased diastolic time available for LV filling and loss of atrial contribution to LV preload. Most likely cause of the right lower limb pain is because of DVT. Immediate synchronized cardioversion would be indicated to improve the cardiac output. Decreased urine output is due to both prerenal and renal etiology, and the best method of ruling out LA clot is to do a transthoracic echo. So you can see very well that this patient is progressing to cardiogenic shock. So first option is true. The most likely cause of right lower limb pain is due to DVT. It is unlikely, because from this pain, this is sudden onset pain in the lower limb with history of cough. So you can very well clearly identify that why these statements B, C, and E are false and others are true. So this is the patient of chronic low cardiac output. Acute worsening is because of tachycardia. Most likely cause of lower limb pain is because of thromboembolic event due to LA thrombus, which can be ruled out by TE and arterial Doppler. And decreased urine output is because of low cardiac output as well as rhabdomyolysis. So it needs urgent heart rate control, anticoagulation, vascular surgical intervention, and renal replacement therapy. So a post-operative AVR patient with an intraarterial line has a funny local intercardial stays with peak pressure and pulse volume changing with every alternate beat. So what can be the reason? So severe LV dysfunction, it is true. Severe hypovolemia usually doesn't cause. Persistent LVOT gradient in patients with HOCAM, that is hypertrophic obstructive cardiomyopathy, can cause. Patients with ventricular rhythm abnormalities like bigeminy can cause. Mechanical prosthetic valves usually won't cause such change in peak pressure and pulse volume. So this is what is called the pulses alternance, which keeps varying at times in the intraarterial trace because of impaired LV function. Rarely this can be seen with hypertrophic obstructive cardiomyopathy with left ventricular outflow tract obstruction, and this disappears with myocardial resection and correction of LVOT. So that is why surgery has a place, and bigeminy can manifest as pulses alternance because of premature ectopic bit, which is associated with shorter dystole because there is impaired LV filling. Mechanical prosthetic issues can lead to a fixed obstruction, but does not cause such a variable obstruction. So thank you very much. I hope it was useful.